He's an internationally recognized lymphoma expert. Dr. Dunleavy is a medical oncologist and hematologist who also serves as a section chief hematology and disease group lead malignant hematology for MidStar Georgetown University Hospital at the Georgetown Lombardi Comprehensive Cancer Center. Dr. Dunleavy earned his medical degree from University College Dublin and completed fellowships in medical oncology at University College Dublin and the National Cancer Institute, where he also continued to work after his fellowship as an attending physician and clinical director of the lymphoid malignancies branch. Before joining MidStar Health, Dr. Dunleavy also was a professor of medicine, director of the lymphoma program, and also co-director of the microbial oncology program in the Division of Hematology and Oncology at George Washington University Cancer Center. Dr. Dunleavy also served on the scientific advisory board of the Lymphoma Research Foundation and also on the editorial board of several journals. He has published more than 100 manuscripts and textbook chapters and frequently presents his research across USA and the world. His talk today is about how I treat aggressive B-cell lymphoma in 2022, including double expressors and double hit lymphomas. Dr. Dunleavy, please, the mic is yours. Without further ado.
Thanks very much, Dr. Al-Makadi, and thank you very much for inviting me to the meeting, and thanks to the organizers of the meeting for inviting me to give this talk today. My name is Kieran Dunleavy, and I work at Georgetown University in Washington, D.C. And today I'm going to talk about how I treat aggressive B-cell lymphoma in 2022, and include a focus on how I treat double expressor and double hit lymphomas. And I'm just working on the control. Let's see. You can just give me the control here. Yeah, great, excellent. These are my disclosures. So I'm going to start off with a case. I think it's always helpful to present a case history to illustrate some of these discussions. This is a 68-year-old male who was previously well, had no significant medical history, and he presented with a 4-week history of fevers, night sweats, and weight loss, and also had bilateral neck nodes. All of his labs were normal, apart from an elevated LDH. Imaging was performed. He had diffuse lymphadenopathy on both sides of the diaphragm, and a biopsy of a large neck node was performed. This showed diffuse large B-cell lymphoma. It was CD20 positive, CD10 positive, and BCL6 positive. By immunohistochemistry, MYC was strongly positive, as was BCL2, as you can see here in the panel on the right, and FISH was performed, and by FISH, he had evidence of both a MYC and a BCL2 rearrangement. His bone marrow biopsy and CSF was negative. So, according to the current WHO classification, this patient had a diagnosis of high-grade B-cell lymphoma with a MYC and a BCL2 translocation. And how would you treat a patient like this? And we can talk about this throughout the talk. Would you give him standard R-CHOP treatment? Would you treat him with a more intensive approach with treatment like Codax-M, IVAC, or rituximab, dose-adjusted EPOCH-R? Would you give him R-CHOP and then follow with autologous transplant? Or would you try something new like R-CHP with polatuzumab based on the recently published data? So if we look at all patients with diffuse large B-cell lymphoma, the cure rate for patients is a little bit above 70%. And we've done a very good job of identifying which patients will not do as well as others. The International Prognostic Index looks at age, stage, LDH, ECOG, extranodal sites, and that is a very robust predictor of how people will do. And if you look back at studies, over the last 40 years, the IPI has remained very relevant and very prognostic, as shown here in the first Kaplan-Meier curve. You can see that low-risk patients have a much better outcome than high-risk patients, according to the IPI. And what's a bit less clear, and I'll talk about this, is the impact of the molecular biology of DLBCL on outcome. Most cases of DLBCL are GCB or ABC, and several studies have shown that the outcome with the ABC subtype is inferior to the GCB subtype. This is some of the initial work that defined cell of origin in diffuse large B-cell lymphoma. This was work that was done over 20 years ago by the Lymphoma and Leukemia Molecular Profiling Project. What they did was they applied gene expression profiling to a few hundred cases of DLBCL, and they showed that most cases could be divided into one of two types, a germinal center B-cell type or an activated B-cell type. And since they did that initial work, our understanding of the molecular biology of diffuse large B-cell lymphoma has really advanced significantly. These are two pretty recent papers, one from the Stout group at the NCI and the other from Margaret Chip's group at Dana-Farber. The paper was written by Bjorn Chapoy. And these are really updates of the molecular classification of diffuse large B-cell lymphoma. They still consider ABC and GCB, but I think what is significantly different is that the absence or presence of various critical mutations are looked at here. And now diffuse large B-cell lymphoma in these most recent classifications is divided out into several different clusters. So it is a more complicated and more refined classification of DLBCL compared to the original gene expression profiling data that I showed you. So moving to high-grade B-cell lymphoma, there's really a lot of interest in this. And a few years ago, the World Health Organization introduced a new category of lymphoma called high-grade B-cell lymphoma. Most of these have got a MYC and a BCL2 translocation, but there are cases that do not, and these are called high-grade B-cell lymphoma, not otherwise specified. The reason that they we're really focused on this is that these patients have a worse outcome. Shown on the left are all patients with DLBCL. And you can see that patients who have a double hit lymphoma, defined by a MYC and a BCL2 rearrangement, have got a much worse outcome than those who have DLBCL not otherwise specified. And the third study here shows the difference between having a MYC rearrangement and not. And people who have a MYC rearrangement have an inferior outcome. What about double expressors? So not only is harboring a MYC and a BCL2 translocation important, but if you have high protein expression of MYC and BCL2, even if you do not have rearrangements, that is associated with a worse outcome. And in terms of trying to understand all of this and put double hit and double expressor in the context of cell of origin, I think it's important to think about where these tumors lie with respect to GCB and ABC. So about 30% of aggressive B-cell lymphomas have got a BCL2 rearrangement. These are almost always of GCB origin. About 10% have got a MYC rearrangement, again, almost always of GCB origin. So most of the cases of double hit lymphoma with MYC and BCL2 are of GCB origin. There are cases that have got a BCL6 rearrangement. These are much less common. And the BCL6 rearranged cases, interestingly, are more likely to be of ABC origin. And here you can see that there are double hit lymphomas. Most of them are MYC BCL2. Some are MYC and BCL6. And then you can have triple hit lymphomas, which have all three rearrangements. But if we think about double expressor lymphomas, they're very different because most double expressor lymphomas that do not have the rearrangements are of the activated B-cell subtype, as you can see here. So I think it's really important to consider the presence of MYC and BCL2 aberrations, particularly in the context of cell of origin. And as I said, the World Health Organization has now categorized high-grade B-cell lymphoma as distinctly from diffuse large B-cell lymphoma NOS. So currently, there is a category DLBCL NOS. Then there's a category high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 translocations. High-grade cases that do not fit into this first high-grade category are called high-grade B-cell lymphoma NOS. And shown here are the relationships of MYC, BCL6, and BCL2 to these different categories. And there's really a spectrum of diseases here. These high-grade cases are really cases that are in between diffuse large B-cell lymphoma, NOS, and Burkitt lymphoma, sharing features and characteristics of both. There also has been some very interesting work that has looked beyond the presence of translocations in looking at aggressive lymphomas that have double hit biology. On the left here are results from a paper that was published by the British Columbia group, where they looked at over 100 cases of germinal center type diffuse large B-cell lymphoma. And really the important conclusion of what they found is that a significant number of cases have got what's called a double hit signature, but only about half of those have got the rearrangements of MYC and BCL2. And those cases do much worse with R-CHOP. Likewise, a British group defined a group of diseases with a molecular high-grade signature. And again, some of these had the rearrangements, but a lot of them didn't, and they had a much worse outcome with R-CHOP compared to cases that did not have this molecular high-grade signature. So with considering all of that, how do you approach cases of high-grade B-cell lymphoma currently? And I would say that it is not straightforward, and we are still really trying to figure this out. The big questions that come up are, is R-CHOP enough for these patients? If they have limited stage disease versus late stage disease, is that different? Is the role of R-CHOP different in terms of using it as a standard treatment? If you have high stage versus low stage, or high IPI versus low IPI. Are intensive regimens better for these high-grade B-cell lymphomas? We know that Burkitt lymphoma does not do well with treatments like R-CHOP, so should we be using more intensive approaches for patients with high-grade B-cell lymphoma? Should these patients get a consolidative transplant? We know their outcome is bad with R-CHOP, so should you follow R-CHOP with an auto transplant? Is that a reasonable thing to do? And what about checking the CNS at diagnosis? And should you give CNS prophylaxis to these patients? This is a huge area of controversy. At our recent ASH meeting, there was a lot of focus on this question, but really the bottom line is that there is still a lot of uncertainty and controversy about whether or not people should get intrathecal prophylaxis if they fit into certain risk categories. And unfortunately, it's a difficult question to study, and there really is a lack of prospective studies that have adequately addressed this question. So in terms of informing us about how to manage a patient with high-grade B-cell lymphoma, I've shown here some critical studies that I think are helpful in informing us how these patients do with various approaches. The very first study is a large study that was led by Andreas Rosenwald. It's called the Lunenburg Consortium, and he looked at over 2,000 cases of diffuse large B-cell lymphoma, surveyed them for a MYC rearrangement, found it in 11%, and showed that a MYC rearrangement was associated with a shorter PFS and OS. In that study, the survival curves are shown here. So if you have a MYC rearrangement, that's worse. And what was really interesting was that the MYC partner gene mattered. So if you had an IG partner gene versus a non-IG partner gene, this was associated with a much worse outcome. Other studies have shown this before, but this certainly was the largest one to show the negative prognostic impact of having an IG MYC partner gene. Next are two studies, one that I led using dose-adjusted EPOCH-R in MYC rearranged aggressive B-cell lymphoma. So based on data, which we did in a single center study, we did a multi-center study in the US, accrued 53 patients, and they were treated with dose-adjusted EPOCH-R. They all had a MYC rearrangement, and about half of them were double-hit lymphomas. And in that study, we showed that the 4-year EFS and OS were 71% and 77%. So really, although it was a single-arm study, we did not see a significantly inferior outcome compared to DLBCL NOS. Another group, the Hoven group from the Netherlands, They combined lenalidomide with R-CHOP in a similar group of patients, and again showed good results with a 2-year EFS and OS of 63% and 73%. Shown here is our study with dose-adjusted epoch-R. And what's interesting is that the double-hit patients did not do any worse than the single-hit MIC-rearranged patients. The regimen is very effective in Burkitt lymphoma. This is a recent study that was published in JCO of 113 patients with Burkitt lymphoma who got the regimen, and the results were excellent with that approach. And these last 3 studies looked at more intensive regimens for patients with high-grade B-cell lymphoma. I think the last study here, which is a French study, is interesting. It was a retrospective study. These patients all had high-grade B-cell lymphoma, and they received either R-CHOP or some kind of intensive therapy. And the patients who received intensive therapy had a much better outcome. Their 2-year and 4-year PFS were significantly better than those people who received R-CHOP. And this is an alliance study that was just presented at ASH by Jeremy Abramson. They combined venetoclax with dose-adjusted epoch-R in a randomized study in patients who had double-hit lymphoma. Now, you can see from the PFS and OS here, and this is an early presentation just from a few months ago, that patients who got dose-adjusted epoch-R, they did well. But the group who got venetoclax, who were randomized to get venetoclax with epoch-R, did not do well. And the reason for this was toxicity and inability really to tolerate the combination. So as a result of that, the study was actually stopped early on. And in the context of all this, I think it's interesting just to mention the POLARIX study, which was recently published, which compared R-CHOP, of course, to R-CHP with polatuzumab and demonstrated a significantly improved progression-free survival. And the question is, how does that apply to high-grade B-cell lymphomas? And we don't know the answer to this, but I think it's very interesting to consider in the context of what we're talking about today. And how do you approach patients with relapsed and refractory high-grade B-cell lymphoma? Well, there really are several novel approaches that are particularly interesting for these high-grade cases. CD19, of course, is a very interesting target. We now have CAR T cells that are approved in several countries, and monoclonal antibodies such as tafasitamab or loncastuximab, which is an antibody-drug conjugate, which all target CD19. Another way of targeting high-grade B-cell lymphomas is by using bispecific antibodies. Several bispecific antibodies targeting CD20 and CD3 are currently in development, and they've shown very good results in both aggressive lymphomas and in high-grade B-cell lymphomas, but also in follicular lymphomas. And of course, there are other ways of targeting high-grade B-cell lymphoma. More specifically, there are inhibitors of MYC, BCL2, EZH2, for example. And then, as I've talked about, polatuzumab and other strategies such as targeting HDAC and immune checkpoint inhibitors are also interesting to consider. As I said, there's a lot of controversy about CNS-directed prophylaxis in high-grade B-cell lymphoma. There's no doubt, if you look at studies retrospectively, that these patients have got a higher risk of A, having CNS involvement at diagnosis, and B, developing CNS progression during or after treatment. But the role of prophylaxis is unclear. It's a really poorly studied area, and you know, in a lot of clinical situations, I think it's fair to say we don't know the benefit of giving CNS-directed prophylaxis versus not. And when a decision is made to give it, it's not clear which method is best, whether you give intrathecal or intravenous methotrexate, or you use other drugs in addition to methotrexate. So as I'm nearing the end of this, this is a summary of how I approach aggressive B-cell lymphoma. And obviously, I think that at initial diagnosis, assessing morphology, immunohistochemistry, and FISH studies should be done in all patients to help to divide cases into these three different categories. For those cases that are DLBCL NOS, if in terms of what we're talking about MYC and BCL2 expression, if they have high MYC and high BCL2, they tend to be of the activated B cell subtype. And we know that they have an inferior outcome. And I think that a clinical trial should be considered in these cases. The second category here is high-grade B-cell lymphoma with MYC and BCL2 translocation. These are almost all GCB. If they have a high IPI, I think that intensive strategies should be used and a clinical trial should be considered. For those cases that have low IPI and are high-grade B-cell, double hit, etc., and there are some studies showing that they do okay with approaches such as R-CHOP. But again, I think that intensive therapy should be considered if they are high-grade biology. And then the third category here is high-grade B-cell lymphoma NOS, which is a very rare group. You know, really, these are high-grade cases morphologically that do not fit into high-grade B-cell lymphoma with MYC and BCL2. And there's no standard on how these should be approached. But again, I think taking lessons from how we treat Burkitt lymphoma, I would approach these with an intensive regimen. As I said, whether or not you check CSF at diagnosis is controversial, but I would do it in these high-grade cases. And then in terms of instituting prophylaxis, I would have a very low threshold to do it, but understanding that there is not robust data to support it, and it is an area of ongoing investigation. And in talking about the double expressor lymphomas, most of these fit in here. They are DLBCL NOS that do not have the rearrangements, and they are usually of the ABC subtype. And I think that for double expressor lymphomas, clinical trial is the most appropriate treatment to consider if that's available, because their outcome with standard treatment is very poor. So to finish, high-grade lymphomas, double hit lymphomas, double expressor lymphomas represent a huge therapeutic challenge in DLBCL. They do make up a very high proportion of cases. There's controversy as to their optimal frontline approach. We know from various retrospective studies, and I would say that it's not completely well worked out. There are some studies that have shown that these do okay with R-CHOP, but for the most part, they have not done very well with R-CHOP. So I think it's very reasonable to consider other approaches, but at this point in time, we do not have good randomized data to firmly support one approach over another. But in my practice, I treat almost all of these cases with an intensive strategy. They're biologically very heterogeneous, and we continue to try to get a better understanding of their biology and to categorize them better. And I know that in the upcoming WHO classification, their categorization is going to change again to reflect where we are with understanding their biology. And with that, I thank you very much for your attention, and I'm very happy to take any questions. Thank you.